audacity, the audacity of Instagram a while ago. Instagram. All right, guys. 1 second. I'm just trying to get everybody back on. We passed the hour.
Yeah.
The audacity of
Eh?
Instagram. No warning. No warning.
No warning.
The
No nothing.
audacity.
That's
And
one.
the audacity of Instagram. They just kick me off big time. No warning.
I come style the show.
Come style
Eh?
show. Just want to get into the
Style the
juicy
show.
part right now.
Don't they normally warn you though?
And yeah, they normally warning. I got no warning. It just ended. I get Jody online.
Where
And it
Jody?
was going good enough. Just send the invite a while ago. People are coming in at the end. I don't know if you noticed.
Yeah, man. Everybody have the burning questions, you know.
Yeah, man.
Yeah,
Have the questions.
I think they're ready for the
Jody,
question.
send the request. It's saying you're unable to join. Send me the request like last time, please. Just send the request, Jody.
The burning
Man,
questions.
everybody, yo.
Ready now.
Everybody is looking forward to the question.
Wait, we have somebody taking note of the questions?
Well, I saw.
No, man, I'm going to ask again.
They're going to ask him again.
Or they're going to ask again?
Yeah, man.
Big up
So,
Jamila. Jamila have a million questions.
Yeah.
I hope we were right. We wrote down some of them that she was asking from before.
No, man, she can ask them again. Don't worry. She can ask
Everybody
them
else
again.
again.
Okay, good. Ask the
So,
questions again.
guys, we'll have about just 3 more questions, and then we're going to have an open forum for the patients. So let me just get through this.
All right,
And
let's
then,
get through.
Yeah.
And then the rest of the live is for you guys.
Freestyle.
Freestyle.
After that.
Well, we never ever get a warning that time.
No, the audacity. The God.
Oh, yeah, that's true. Yeah, hold on. That's a good idea from Jamila. Everybody, when you guys have questions, use the question. You can just use the question button.
I've been getting them, you know.
Oh, you've been getting them. All right. Yeah, that's how to send all your questions there.
Send to the questions there.
Yeah.
All right. So the next question we have is very important question, and we can talk about it for the rest of the presentation. But what does it mean for future pregnancies?
True.
All right. So a popular question. So there was a saying, once a C-section, always a C-section, and that has been not true, but people in the older days, 70s, 80s, that was something that they stood by and followed through. As we advance in our medical knowledge or experience or monitoring or studies, we realize that we can allow patients to deliver vaginally, right? So the whole process of allowing a patient to deliver vaginally is what we call trial of labor after cesarean section. So once that child or once that lady has had a successful delivery, we call that VBAC, vaginal birth after
cesarean section.
Right? So there are many criteria that has changed over time. I was trying to see the latest ones, but so you guys can feel free to jump in. Kevin, you there? Kevin look like he get a phone call.
No, man, 2 minutes.
Okay, all right, so he's there.
Yeah,
right, so the criteria, so like one of the first one is the type of incision that was made on the uterus. So Dr. Jarrett spoke about it earlier. The most common type of incision that we do on the uterus, not the skin, is what we call a lower segment cesarean section. So that's a lower transverse, like a smiley face section right at the bottom of the uterus. That is, and the reason we go there, it has the least blood supply, it's the least vascular, it's the easiest part of the uterus that is associated with the least amount of blood loss. You can also do a low vertical. So instead of doing that transverse, you can do a low vertical. So any woman who has had that is why it's important to have access to the notes, you know, because we don't know what's done at the surgery. So any woman who has done a previous lower transverse section or a low vertical, at least one, we can allow them to have a
trial of labor.
A trial of labor after cesarean section. So that's one criteria, right? And remember, guys, it has to be the most once the patient is chosen correctly, more than likely they'll have a 70% chance of having a successful delivery. So that is one. Because there are other type of incisions you can make. You can make a fundal incision. You can make a high vertical, a high transverse. All of those, a J incision. All of those incisions are contraindicated for TOLA.
Trial of labor.
Trial of labor. I think another one is the weight of the baby. I think the baby has to be less than 3.5 kilograms, and the baby has to be in a cephalic position. No other position but cephalic. The second
Doc,
one
what is cephalic?
Thank you.
Head down, head down.
Head must be down. Baby must turn.
Baby must turn.
Baby must have turn.
Baby turn, not turn. Baby head
Thank you, Kevin.
Yeah, man.
Thank you, Kevin.
I don't like how Doctor use all them big words there, you know.
The big word,
Thank you, Kevin.
like.
Thank you, Kevin. Head down, head down. So the baby have to be about 3.5 kilograms. How much pound? About 7 pounds, 7.5.
7 pounds. Yeah.
About
7
about
pounds.
7 pounds.
7.5.
7
7 and a little
pounds.
bit. Yeah.
And head down. And we mentioned the incision. Another criteria also must be the timing
From the last.
from the last delivery.
I think
So,
it's what, 18 months?
it was
18 months.
I'm now hearing it's 12. I don't know. So
Yeah. I think the latest thing is 1 year.
No, 12. It's 1 year. So what that means is you can attempt a trial of labor within 1 year of the last delivery, right? Before it was 18.
Meaning, okay.
Meaning since the baby born and you're supposed to deliver the baby 9 months ago, right? And you're pregnant as soon as you got pregnant as soon as you had the last
6 weeks.
baby.
Yeah.
Yes,
You're definitely not getting
you're definitely not. You can't. You're not
Within the year.
You're within
Yeah,
the year. You're within the year, right? So cephalic, weight, time, and the number of C-sections as well. Before it was always one C-section. So once you've had one C-section, would allow you, but now we've gone to 2. So once if you had 2 or more,
They have gone to 2.
they have gone to 2.
They have gone to 2.
They have gone to 2. We're going to talk. I'm just speaking generally right now. They have gone to 2. So I'm just speaking an ideal word. So number of C-sections, incision, weight, and position of the baby, and the timing. Those are the most important factors that will influence a trial of labor after cesarean section. And in the most well-chosen patient, the success rate is pretty high, up to 70%. But you have to have continuous fetal monitoring.
Fetal monitoring,
Meaning
right.
that the mother and the baby, because what you're concerned about is what we call uterine rupture. That is when that the cut that we made on the uterus initially for the first C-section. It's a point of weakness, and when the uterus is contracting, that wound actually opens up and it's detrimental for mommy. Mommy can bleed and baby. Right, so the placenta and the baby can just go straight into the peritoneum, and that's a problem. So that's a main concern when we're talking about trial of labor after C-section. So fetal monitoring must be there. You must have emergent access to a emergency C-section setup, right? So anesthesia must be there, obstetrician must be there, pediatrician must be there, blood available, like. It has to be like the most perfect
ideal
setup.
Ideally, it's not like that, but I'm just speaking from a first world perspective, right? But it can be pretty successful. You know, it happens all the time in the correct patient.
Yeah.
In the correct patient.
I didn't read because I remember when we were in school, they had said you have to go into spontaneous labor. No oxytocin use, but I read recently that they allow oxytocin.
Oxytocin. I don't think they allow
no
induction. No induction.
No
misoprostol induction, but
you can augment.
You can
they can augment.
How could I forget? Multiple pregnancies are not included in the So big. If you have twin pregnancies, don't even think about it.
Yeah.
I don't even think about it. So that's a topic by itself, and I know
that uterus already under pressure.
Yeah, man, that uterus really under pressure. All right, let me just try to wrap up these questions, guys. We're doing good. Mandy, last question. Complications of C-section.
All right, so we have
Floor is
many
everybody's.
different complications. Because I know some people will say, okay, we take away the pain, but there are risks involved. So you, as Jody mentioned, you're cutting into a lot of tissue, so there's a risk of bleeding. And sometimes a woman can bleed excessively. Sometimes it gets to the point where it's so bad, which is a very rare occasion, but it happens where you bleed so much that you have no choice but to do a cesarean hysterectomy, which means you take out the whole wound to prevent the bleeding. Of course, that's only done in cases of life or death matter, but it's something that can happen. There's always the risk of infection. You open to the outside environment. So infections can be in the cuts, in the womb, sometimes in the bladder. But of course, we give you antibiotics during the procedure and after to prevent those infections. You can have what we call clots. So we can have blood clots forming, sometimes from your lungs, that can go, sometimes from your legs, that can go to your lungs. These things can be fatal. So that's also why you may notice after cesarean section, you get injections to help thin the blood to prevent those from happening. During the surgery also, anything that we encounter can get injured. So you can get the bowel can get injured, the bladder can get injured. Sometimes even baby can get little nicks on the scalp or so. So these can happen. These are also complications of surgery. Anything else you want to mention?
Infection, bleeding, risk of blood transfusion.
Yeah, if you lose a blood transfusion.
Okay. I think that's essentially it. Infection. That's a major one.
Anesthetist would go through with them in terms of the
anesthetic complications.
Complication.
Yeah.
One thing that they're to expect, which is it's not really a complication because it eventually comes back, but sometimes you have like a numbness or like a right over the incision, because of course we go through nerves and stuff when we're making the incision, so it takes a while for those nerves to regenerate. So a lot of times you'll see that doctor can't feel and it's actually numb, or it may have itching and stuff like that to the skin. So those things are things to expect. So not necessarily complications, but things to expect post-operatively and during the recovery process.
Mm-hmm.
All right, so I think we've touched everything. We're going to jump into the questions now. Oh, and just a simple thing I don't think we mentioned, what is important. So just for clarity, we have the skin incision and we have the uterine incision, right? So the skin incision doesn't necessarily equate to the uterine incision. The most popular skin incision is a bikini cut or a fanning steel incision. Some women may have a midline incision, but that doesn't influence the type of incision that we make on the uterus. Sometimes some women may have some large lower segment fibroids or that are previous surgery before and that are previous midline surgery. So we have to go through or do a midline approach. But the classical approach for a cesarean section is a bikini or a fanning steel incision. Because I know that's going to come without even looking at this question. All right, so let's jump into it. So we're going to do tag team now. So I'm going to tag Mandy in first.
Freestyle.
So you just look on one randomly.
This is the best part of the live now, by the way, guys.
This is the best part.
I know when you answer the question.
Fire. All right.
The question's always loud.
All right. This is from T Nita. Mandy, is there anything you can do to avoid a spinal headache?
You can fit it.
Yes, you can drink lots of fluid. You can drink lots of caffeine. And there are also medications your anesthetist or your doctor can give you. So you can just speak to your doctor about that. There are medications you can be given straight after, but a lot of fluids and a lot of caffeine that can help prevent it.
And try not to overdo it in the first couple of hours like I did. So don't move your head up and down. Try to, do too much too soon, because that also affects the spinal headache.
And sometimes it can be very extreme. You may need to give some steroids.
Yeah, the steroids one thing. My anesthetist sometimes gives them prophylaxis. Before you even feel the pain, she gives them to help prevent you from feeling pain.
And remember, not everybody will get spinal headache, guys. It's not a mandatory.
No, definitely not.
But it's something definitely to look out for and be on the alert, just in case. All right.
Like for every 10, probably one person gets a spinal headache. Go again.
You know, Jody. Can an emergency C-section result in a hernia?
Any C-section can result in a hernia, actually. Any incision at all.
Any abdominal
incision, whether it be for C-section, appendectomy, ovarian, cystectomy, any kind of surgery, mammectomy, hysterectomy, any incision can result in a hernia. What happens with a hernia is that when you're doing your repair and you bring your fascia cloak back together, what may happen is that something may affect the healing process. So it could be that there was too much pressure during the healing, patients trying to do too much, etc. But the healing process is affected, and so you get a weakness in the fascia, and then that is when you get like bulging of the abdominal contents through, and that's what gives you the hernia. So it's any surgery that you do at all can end up with a hernia. So yes, and a C-section, emergency C-section can up in a hernia, but it's not doesn't have to happen, and it's not only related to an emergency C-section. So any surgery that you do at all can end up with a hernia.
Just to add to that something that can potentially happen though is when you have like diastasis of the rectus. So what that is that it's not a hernia, but what can happen is those same abdominal muscles that will separate to get down into the uterus, right? Usually what happens naturally is that they come back together and form back your abs, right? Now, not all times will that happen, and so instead of the muscles coming back together like this, you can have a little gap between the muscles, and so you may feel like not like a hole, but you can feel like a sinking
like
in the muscles, which usually physiotherapy is very good to help to close that gap, but sometimes it may require like a minor surgery to close up that little gap.
I mean, and that can also happen with regular vaginal deliveries as well.
Right, yeah.
So it's not
the sheer pregnancy is pushing
pregnant,
it
right?
Pressure,
right. The stretching of the abdomen and the abdominal muscles during pregnancy can also cause separation of the diastasis.
Not just the surgery.
This is a good question. I'll take this one. If you have surgery for an ectopic pregnancy and then require a C-section, is the previous incision reopened, and is it the same kind of surgery? So entering the abdomen is always the same. So if that a previous ectopic, more than likely they had a bikini or a Fanning steel incision or a bikini cut. So what we would do, we normally, when we're doing any previous surgery, we normally take out the old scar and we enter the abdomen a little bit more meticulously because we're expecting scar tissue. Just like you have a scar tissue on the skin, you can have scar tissue at every layer that Dr. Jarrett mentioned earlier, going into the abdomen. And once you enter the abdomen, you can even have scar tissue and all the organs are stuck down together, adhesions, So the same principle to enter is the same, but we're doing a different thing. With an ectopic, we're just taking out the fallopian tube that has the pregnancy in it. Once we're in the abdomen, we're going to open up the uterus, as we mentioned, via the different incisions, take out the baby, take out the placenta, and close the uterus. So two different parts that we're operating on.
So it's not the same surgery.
But the same entry technique.
Yeah, the same. We go through the same scar.
Same skin.
We don't give you a new different scar somewhere else.
Yeah, but we usually cut out the old scar just for cosmesis, because normal skin to normal skin heals better than scar to scar, right? So that's essentially it. Kevin, you're next.
But important to let them know as well, because especially in the public system, that but me did have ectopic 2 years ago. That mean me have to get C-section?
C-section?
No.
Yeah, no.
99.9% of the time, if you've had a surgery for ectopic pregnancy, we didn't have to cut the uterus. All we did was took out a tube, so you can have a normal vaginal delivery after that. You'd have to get a C-section.
Unless it's the cornea.
Unless it's a cornea.
Ectopic is right between the tube and the uterus, right at that junction. So you do have to remove a part of the muscle of the uterus. So that is the only time we'll recommend a C-section, because when you go into labor, that part that removed
Is that no point of weakness?
Is a point of weakness and can rupture. All right, I'll get to the questions. I'm coming in, So I'm just trying to keep up with them. Kevin, what's the reason for the spinal tap as against putting the patient under? We kind of mentioned it before.
I think I had said
All right. Can pushing cause the cut to open up?
Can pushing cause the cut to open up? Meaning if you've had a C-section before? Yeah.
I'm assuming the skin to open up. I'm assuming
the skin.
Or
no,
you can
so
break
the
it
skin
down.
would.
You can break it down.
Yeah. So if we're going through all of the layers, it is highly unlikely for the skin to open up from pushing. It is more likely that the cut that you have on the uterus itself, that old scar. Because remember, imagine a knife cuts you on your arm, right? That scar that is formed, the skin that is actually formed in that scar, that skin is weaker than your regular skin, right? So say your skin is 100%, that scar might be 95%. So there's the potential that weak part on that scar in the uterus can open up, but not your skin. Your skin not being open. The day I see a patient's skin open, me run out of that room, something is up.
Can I stick up in, please? All right, can I stick up in?
I've heard Daryl's story.
All right. I told you the story on Monday. All right. I've
heard Daryl's story.
Okay, all right. This is crazy. So a patient,
it's only Daryl and thing here happened to you.
It's only Daryl. That is why I wanted to answer so I could have come in. And she knows herself. I wonder if she's watching, but very lovely lady. Routine surgery. I don't remember what the indication was. Routine, 100 ml blood loss, easy breezy, nothing. Small girl. I don't remember what the indication was. It was an emergency though, but it wasn't like an infection situation. It wasn't like chorioamnitis or anything like that, which is an infection of the amniotic fluid. I don't remember what it was, but we did the surgery. She came back for her 1 week visit. And she told me that, remember I used the spray, the upside spray. She said that there's a bulge coming out. And I said, a bulge coming out? Bulge coming out? When she took off her clothes, the half of the wound was open and there was bowel out. And I was telling you, it was the scariest thing ever.
He said. To the nth degree.
Complete fascial dehiscence, wound dehiscence.
With no infection at all?
No infection at all. So I carried her back. I did her at Andrews. But obviously cost was a factor. And this is the great thing of working in the public sector.
Yeah.
Carried her back to Maypen. Went in, called general surgery, inspect the bowel from beginning to end. Close her back. Close her back with Proline. Proline is a type of stitch that we use, but it's non-absorbable.
So it's stronger.
She was perfect. But that is. Monday, I told you about that one.
I remember that story. I was like,
listen, I've seen.
I've never seen that happen on the
not in the private.
We've seen that before, but usually it's like, if the wound gets infected and then, it's not even properly set open up.
I had a patient, she wasn't infected either. It was our public patient. We ended up having to section her. But she had COVID. So we had to section her with her COVID. So, we have to do the section in all our PP. This is during the heights of COVID, And I'm like, please just let this lady deliver. And of course she didn't deliver. We had to do an emergency section on her. And 2 days later, we went home and came back, bowel everywhere.
Wow.
And there was no infection anywhere. Yeah.
Come on, call it the COVID.
Call it COVID.
Yeah,
COVID.
But I found, honestly, all right, so it may be, there's no studies done clearly, but most of my patients who had COVID that we ended up having to section or something like that, they all had either delayed wound healing or suture pull out or something like that.
That's interesting.
No, seriously.
Yeah, maybe there's just some form of, like immunosuppression with the virus itself and so it impacts the healing.
when the lady come back in a hole in her, she had like a towel over her abdomen. I was like she went home in the morning and come back in the evening. I had to carry her back to theater. It was crazy. But I've never seen it any other time.
It's pretty crazy. Yeah. I just need to see one time. I just need to see one.
Yeah, man, that's one alone.
Yeah, that's one. I don't need to see that again. I don't need to see that again.
And listen to what they're saying, because you don't expect her the way she's describing the bulge. Yes, but she's so quiet and so. Yes, that little bulge just coming out. You know?
Yeah, little bulge.
I just want to pull up my pants, you know. Let me just make you see for yourself. And she was so calm, lovely girl. Wow. She's perfect now. All right, let's get into this now.
Yes.
At what point is it ideal for a cerclage to put in? Mandy, you can take that. Let's go back around again.
At what to take out or put in?
Put in. So what point in time is it ideal for a cerclage to put in?
But how that's related to C-section though? But anyway, so it depends on the indication, because sometimes we do them prophylactically, and sometimes we do it if it's a rescue cerclage. So if it's a rescue cerclage, it's at whatever time the cervix is shortening. Otherwise, it's normally 14 to 16 weeks that they're present.
We're not getting too much into that. I'll give you a next one.
Stick to the topics, guys.
Questions.
Please.
How many times can you do a C-section? Good question. Very good question. Monday,
You know, I don't want to answer to that. Let me tell you the truth. When I just came and started working at Cornwall Regional, they had a limit of 3 C-sections.
3. Mm-hmm.
However, I was told it was not a legal limit. It was just something that was strongly advised. And if a patient decided that she wanted to have more, we could not stop her from having more.
I did the 5th C-section 2 weeks ago.
Really? So I don't think we have a legal limit. Yeah. We just have a medically suggested limit of 3.
And remember, you can't force a patient
to take a TL.
To do a tubal ligation if she doesn't want to. It's her
body. If they want more, they can.
If they get pregnant, somebody has to deal with the consequences. And 9 out of 10 times is the public system doctors that do.
Yep.
9 out of 10 times. So I did my first 5th C-section last year. Two weeks ago. But the 5th time we're going in. 5th. And it was perfect. It was like she never had surgery before. She did a TL. She did a TL, but it was
yeah,
perfect.
I think that wasn't. I don't think that was for C-section reason though.
Huh?
I kind of don't think the 5th C-section, the TL after the 5th C-section was for the C-section. I think she was probably like, yeah, take my football.
She finished.
Yeah.
Football team. Yeah. All right. Get through. All right, Kevin. This one is for you. Typically, Jody answered that already. The numbness. Okay. My cousin had a C-section last week, and one day after she come home, she started to bleed heavily vaginally. Can you explain?
I mean, it could be for how long after? A day after?
One day after she came home. So probably like day 4.
Okay. So it could be a number of things, right? It could be that the uterus itself, for whatever reason, isn't contracted as well as it should be. So if the uterus, gets a bit soft and isn't contracting down, then because it's not contracted, you can have a lot of bleeding from the uterus. It could be that there was some issue in terms of with the C-section itself. So it could be that there's bleeding coming from the scar on the inside that is going inside the uterus that is coming out. But if it is that she's having very heavy bleeding, then that needs to be checked out urgently to identify what is causing it, so that you can stop that, because you don't want to be bleeding incessantly.
One of my faves just jumped into the room. One of my patients. Oh, sorry, I said that out loud. One of my previous C-sections. All right, so Jody, this one is for you. Can you rectify a keloid scar from a C-section?
Yes, you can. So we can do injections into the C-section scar itself of a steroid called Kenalog or triamcinolone. And what that will do is kind of flatten it out. You may need more than one treatment of the injections into what we call intralesional injections, so into the scar itself. If those don't work, you actually have laser therapy that can be used to help to treat it, or you may have to do excision and scar remodeling by plastic surgery.
Can do radiotherapy too.
And radiotherapy, yeah.
And next thing, I have to keep on plugging this. Dr. Patricia Yap has this amazing new cream called Keela Flat. It's going to be the next best thing. I don't know what is in it, but she has some very good results. You apply it. It may take weeks, it may take months, but that keloid will get flat and almost invisible. I'm telling you, it's on the verge of something huge right there. Big up, Dr. Yap. I love you. That's a question, a nice question. This one, I love this one. Intimacy after C-section. Oh my God, I love the question.
Take it away, oh shot.
Yeah,
take it away, oh shot.
So somebody did ask about the O shot there.
Yeah.
Not even C-section, just childbirth generally.
Yeah.
It's a psychologically, emotionally changing, and the whole environment has changed completely. And especially for the woman, the last thing on her mind is sex. The last thing on her mind is sex. And as a partner, you need to be very supportive of her. You need to, it's a new
no pressure.
Not only that, it's a new person in the family, a new being, you know. So you as a team, if the spouse is there, let me say, if the spouse is there, have to be there, have to be supportive for your wife or your spouse. Ensure that you help out as much as you can with the baby. Have rest times, you know. Tend to her needs, especially if she had a C-section before. Try to be supportive to her, give her a medication. Try to let her, you know, all the help that she can get. And sex will come when you both are ready. You know, you can't put that time period on it. She's not thinking about sex, especially if she had a horrible pregnancy, a horrible postoperative period, and she's having some postpartum blues, you know?
Yeah, so that postpartum blues is real.
Yeah,
you really have to pay attention to her.
So remember as well, after you deliver, there's still a lot of hormonal changes that occur as well. You know, the hormones from pregnancy are trying to adjust back to normal. So as Daryl said, sex is not the primary thing that a lot of women are thinking about in that immediate time. And a lot of times the patients will come back to you, you know, and they will either, if they come by themselves, they'll say, Doc, honestly, like, him just a pressure me for this sex thing. Please, I want you to say it so that I can go back to him and say, Doctor say, I don't have to
must wait.
It shouldn't be like that. It should be that everybody is on the same page, understanding that it's a transition. It's a new transition that the woman is going through, having delivered. And this goes for vaginal as well as C-section. And it shouldn't be a rush to say. Sometimes you can see to the partners, you know, when they come at the 6-week visit, they're looking for you to say, let's go. They're just waiting for you to say it, right?
They're waiting to give you the go-ahead.
So I always say that, yes, you can go back to all your routine, normal activities, including sex, but it is when you are ready to do so, when you feel comfortable and when you feel ready, you know? It shouldn't be a rushed or a pressured situation.
Just to add to what you said again, I always tell them, the postpartum period is not a light switch. It takes a while, you know. It's not like you turn on the switch and the light come on. Those hormones take about 6 weeks or longer to fully go away. And once those hormones are raging, you know, you're not going to be how you were as you were in a pre-pregnancy state. So it's a sometimes we need as much counseling as pain. The things that women go through is a lot, you know, in the postpartum period, you know.
Definitely.
And every woman is different. You may have your baby mother may have responded one way, your mother may have been different, your wife may be different. So you cannot just use one person to judge others. Everybody's going to have a different experience.
Yeah, but the key is to always be very supportive, help as much as you can, try not to make her feel too pressured or too burdened by what's happening. So if you can take the baby for a little bit, you know, give her a little hour to sleep, rest, those kind of things, it actually really helps. And
Let me ask
when
her.
she
Let me
feels
ask her.
that support, it kind of helps her to kind of go back to, you know, a little more routine functioning.
Let me ask a slightly different question to all of you guys, a different slant, right? What you guys feel about the incorporation of routine, like at least one routine postpartum, either counseling session or like with a psychologist to go through for all patients? And I'll tell you
That'd be
why I asked
perfect.
after.
Perfect.
Mhm.
In the
No, I would
ideal world.
agree. Actually, yeah. Ideally, where you have those things readily available, you know,
Yeah.
definitely.
Yeah.
I would agree with you.
The amount of patients that have come and said that, you know, they 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 don't feel like this is not, it's not like they're struggling in terms of they're having issues, but they would love it if they would be able to talk to somebody that can, you know, break
Give some
things
kind
down
of
from
guidance.
a
Yeah.
mental
Yeah.
perspective. A lot of times, you know, not everybody does the same in terms of adjusting from that
Of course.
pregnancy to after pregnancy period. A lot of
Definitely.
different things happen, you know. Everybody's family situation is different, support system is different. How you respond to a baby in terms of how you thought you probably would have, and then how you actually coping after is
Right.
totally different for
Expectation
every
versus
woman.
reality.
So I think that is, I saw it in a practice in the States where, you know, like when you come, like they schedule it to have, like they have an in-house person that does like, you know, a routine counseling session, literally just to find out how you are, how you're doing, to check your mental health. And then if they think that there is something for concern, then, you know, they refer you appropriately or do further sessions. But, you know, that's one of those things that,
I
That
had one.
sounds good.
I had one recently who, you know, and that's why it's very important to listen to your patients, you know, and
Yeah, always.
her whole, everything was just down. Everything was down
demeanor.
about her. Demeanor was just flat. And I said, what's going on? And this was like a 6-week visit. And she said, you know what she said to me? She said, that you're like the perfect obstetrician, but I don't think you can help me what's going on right now. You know, and she just went on some more, and I said, I think you should get some professional help, you know. And I referred her to the psychiatrist, you know. But that's just so important. You have to listen, and you have to, as a doctor, you have to try to attend to all your patients' needs. You
Yeah.
know,
Definitely.
read body language, ask about them family, ask, don't let, you know, just try to get some
Don't take it for
information on how
granted.
they're doing. Don't take it
Yeah.
for granted.
Yeah, it's
Don't take it
true.
for granted. Don't take it
And
for
as
granted.
well,
Definitely. Definitely.
they are looking to us to be that guide and that support, because I mean, unfortunately, the mental health situation in Jamaica is still somewhat of a taboo and a little bit, you know, of a stigma. And so we have to make it, I think it's our duty to make it as comfortable as possible. It's like you're almost talking about it again. This is just one of the things that you do after pregnancy, you know? Like the
Yeah.
person going to see, it's not to say, I had a patient once actually who was struggling significantly. I thought that she was between blues and depression, right? Where, you know, it could have potentially be affecting the baby. And I referred her. I mean, she was telling me, I mean, me and her are very, very cool, right? She was telling me that, you know, she's struggling pretty much. And I referred her. And she told me that, you know, she really wanted to go, but her partner didn't want her to because of the stigma associated, you know? So it's a lot of other things. And, you know, another one, they told me that, yeah, but the partner is saying that, you know, she just don't know how to deal with her baby. And that is why she, you know, not, you know, says the patients will come to
Yeah,
you
that's
and
true.
you are sometimes that escape for them to kind of,
Yeah.
you know, get the appropriate help that they need. So it's not something that we should take lightly or take for granted, you know?
No, definitely not. Definitely not. I think maybe even I know, like, well, when you a lot of in Jamaica, I don't really hear a lot of patients going to like the Lamaze classes or the actual preparation for the labor and delivery process. But I think if we encourage our patients to find something like that, because I think they kind of touch on that during that whole preparation process for labor, delivery, and the postpartum period, and encourage them to go as a couple, so that
Yeah.
the partner is also open to what may happen, you know,
Yeah.
because a lot of times they don't know what to expect, and they probably think, oh, it's just she have the baby and she don't really know how to deal with it. But she alright, she'll be alright, and kind of brush it under the rug. But I mean, it's something that you can probably encourage them to do leading up to it, and then afterwards as well.
Yeah, the majority of my patients, they do the Lamaze from 28 weeks. They're nurses at Andrews who do it. So I encourage all of them to do it so they know what to expect, and not just them, them and their partner.
Yeah,
it makes a big
difference.
All right, next question. Is it riskier to give birth at the public versus the private hospital? Good question. Good question.
That's your question.
I am of the firm belief, and I know my other colleagues can agree, that I believe that our obstetric care in the public system is very good.
Yeah.
And the reason I say that is because I know the people who work there. I know the people who are in charge there. There are people who I've worked with. They're my seniors, they're my peers, they're my juniors. And I honestly say, in my opinion, there's no bad obstetrician in Jamaica. I always say that. I don't think there's a bad obstetrician in Jamaica. I think everybody is good. So I think when it comes to management of certain problems in pregnancy, what I tell my patients all the time is, in the private sector, you're a one-man band. You have to play every instrument by yourself. And there are certain patients that you cannot manage at all. Like, you cannot manage these patients as much as you want to. You have to make those, at the end of the day, like I said, is this decision right for me, or is it right for the patient? And it's always the patient first. These weird blood problems, why am I looking after that patient in a private institution? And I know Andrews doesn't have a blood bank. I need these patients to be in a situation where they have all the support they need. So the public hospitals, actually, contrary to popular belief, guys, the public hospitals, they have blood support, they have emergency theater support, they have neonatal support, they have surgical support, they have ICU support. What support does the private hospitals have? Dr. Jarrett, Dr. Elliot, Dr. Henry support. That's all it does.
So the thing is, well, so sorry.
They maybe look. Go ahead, Kevin.
No, what I was saying is that it depends on what you're looking at in terms of what you're saying, in terms of which hospital is better, right? You can look at it in terms of from a resource perspective. You can look at it in terms of from an experience perspective, right? You can look at it from in terms of a financial perspective. Like, there are a lot of different things that people will consider a good experience or a bad experience, or this hospital is better for this versus that, right? If it is that you want that individualized care from your doctor, that is the person that is going to see it, that is the person that is going to deliver you and sort out everything for you, then obviously the way to go is private, right? Definitely. But you also have to understand that if you're going to be delivering privately, that comes at a cost. There's no going around that, right? You have to pay for private delivery. If it is that for whatever reason you're unable to afford private delivery, then your next option is the public system. Now, I find a lot of times persons maybe unfairly compare public to private, meaning that they would expect certain things from the public system that they would get in private, and the reality of it is just not feasible because it is the public system, right? There are certain things that you cannot be afforded, or that you just will not get because it is the public system, right? We don't have, whilst all of the things that Daryl mentioned in terms of support is definitely there, in terms of the amount of individualized attention and staff that you may have is not going to be
not there. Definitely not.
Right? Certain things, like even something as simple as the partner not being there for delivery. That may be a big thing to a lot of people. In the public system, it is just not feasible to allow every single relative or every single partner to be there for delivery. And that's for a lot of reasons. That's for infection control, crowd control, a lot of things,
And then for each patient.
It is. So it depends on what you're looking at in terms of to say which hospital is better for what. What I think is the better way to look at it is to explain what you will get if you go private and what to expect if you go public. But it's not to say that you'll be shortchanged in terms of the quality of care. For the most part, I would say
but a
the
lot of
public
people,
I think a lot of times what is the turn off with the public system is that, for example, when you're going to do a vaginal delivery, most of the time it's a midwife that's going to be doing your delivery. So most of the time they're going to be during the labor process. If you're a normal antenatal patient, you're going to be interacting mostly with nurses. You may have a doctor review you every 4 hours just to see if you're progressing, to look, make sure that everything is going well. But the majority of their interaction are going to be with nurses who are going to do the delivery. Whereas in a private system, you have your doctor, and your doctor is the one you see and interact with all the time. So I think maybe what they're expecting when they go to the public system is that they should get more doctor-patient interaction, which they may not be able to get, clearly, because we don't have enough doctors on staff for that. We don't have enough, resources. Nurses sometimes as well. Sometimes you have one nurse to 10, 20 patients.
And the truth is, generally speaking, in the public system, as you said, the midwives are the ones who do the low-risk deliveries. The doctors are only there for complicated deliveries. Breech deliveries, whatever complicated vaginal delivery, that's what the doctors are. Historically, midwives have done deliveries, So that was a good point, Kevin, about, breaking it down, because patients need to have realistic expectations of what they're going to get when they go to public system. And some patients believe that when they go to public system, they're going to get the same thing they get in the private, or what they want to believe in the private.
Exactly.
Right. Remember as well that when in the public system, especially in terms of staffing as well, right? It's a different dynamic if I am delivering a patient privately at Andrews, right? My sole and only responsibility is that patient at that time. So I can give her 100% all of my attention, right? When I'm in the public system and it is me and just one other doctor that is working, and there are 20 patients that I have to attend to, it now becomes a matter of I cannot see all 20 people at one time. So and it's also not going to be a first come, first serve situation. It's going to be who is the most urgent of all of these patients, And I mean, that's how the doctors will have to operate. That's how the nurses will have to operate in that system, because that is what it allows. So it's really in terms of that understanding that it's not going to be the same as if you delivered privately,
I just say a point there. That's true. Private is more convenient. It is convenient, but as Dr. Henry alluded to, it has to come at a cost. At a cost, the cost of the doctor's time, the cost of the doctor's experience. And as Dr. Henry said, our sole responsibility is you at that time. Unless you have 2 patients in labor, which has happened to me already, But you have to juggle the 2 of them. But that is your focus is 100% on that patient. I think we're running out of time, and let me get some more questions.
Yeah. I think we got some most of them.
You guys can see the questions, sir?
I can see some of them.
No, I mean in the how many? Okay.
This
is Jamila. This question is so weird, and I don't want to take it out right now. This is are patients allowed to see their medical records after they felt the medical team has been negligent?
No.
They
have to. No,
right.
I think legally speaking, I think they have to go through their lawyers and stuff like that for them to be able to have access to their records.
I can't tell you how we do it in the public system. I have to deal with this privately, but in the public system, the law.
Jamila, please message me privately. That's a heavy one.
It is heavy. But essentially there's a process you have to go through. The lawyer, and then the lawyer has to request it, and then he doesn't get the notes, but it's sent for expert opinion for it to be reviewed, and then a summary is written. So the actual notes is not seen by anybody but the hospital and the expert opinion. You understand? Those are the only 2 people I think legally can see the document.
Yeah.
But this is nothing. I'm not really familiar with this, But generally speaking, patients really do not have access to their notes. I tell patients it all the time. Generally speaking, you don't have access to your notes. You get a summary of your notes. We can provide a summary of your notes. But the actual physical notes, is usually the property of the hospital,
Is the
or the property
Or the property of the hospital or the
or
government.
the practice.
Right.
Or
So I
the
also
practice.
you could get copies of any test results, any test
Yeah.
done. You could get those, but my notes are mine.
Exactly. It's a concept patients really don't understand, though. You know, patients say, I want my docket. Can't give you a docket. I can give you all the results in the docket, but my notes, as Dr. Elliot said, are my notes. You know,
Yeah.
I can summarize it for you, but you know, it's a difficult concept to understand sometimes. And they said, any other questions? Or they say, how long after a headwater break should a second C-section be done? After 9 hours without having contractions.
They can augment.
We need more information.
No, but
this is a vague.
yeah, no, that's what I'm saying, because generally,
Everything.
if your headwater breaks during trial of labor, then you can augment by giving oxytocin, which would enhance or augment contractions. So
Once everything
this would
else
need
is fine.
definitely once everything else
Yeah.
is fine. So this is a little too vague for us to give a proper answer.
It's very vague.
I think somebody said the question was read but not answered. I think it was the final versus general anesthesia one.
Oh, I think I had said it that. What was the question he said? What's the reason for
spinal versus general.
Right. So what we're saying for the spinal, it's regional anesthesia, quicker recovery time. They're able to be awake during the delivery process, so they get that first few minutes of interaction with the baby, stuff like that. As well as general anesthesia, we may opt to do in a situation where we don't have the time to wait for the spinal to work, and we need to get the baby out a little faster than normal. But we tend not to like to use the general because it can cross the placenta and cause depression of the baby's breathing functions, etc.
And you recover faster out of the spinal.
Yeah, they recover right.
Is it harder to do a C-section on an obese patient? Most definitely.
Yes.
Definitely.
Most definitely. Obesity makes every medical procedure much more difficult. So in an obese patient, other than the anesthetic complications that can occur, you know,
they're more at risk for clots.
They're more at risk for blood clot formation, more risk for
infection,
more risk of
bleeding, hernia formation,
bleeding,
damage to the organs because it's difficult in terms of mobilizing everything and
sometimes you need a second assistant. A lot of times you need a second assistant to help hold back the obesity,
to retract the fat,
or the panicles. How effective is epidural, and why do some people feel pain same way with it? Anesthetic question, but
I mean, epidural is pretty effective in terms of pain relief, and pain management. It's actually beneficial if you end up having a C-section because it's easy to convert that epidural to a spinal without having to do an extra procedure. It should not be that if you're having an epidural, you're still feeling pain. If you're still feeling pain with the epidural, then it probably not necessarily wasn't done properly, but it probably just needed to be. Yeah, they probably need to top up the dose, but it shouldn't be that you're feeling pain when you have an epidural. You may feel pressure, but you're not supposed to feel pain.
I think we have like 5 more minutes.
Yeah, 5 more minutes.
I saw a couple of people asking about, like that they've had a C-section and, like months or, a year later, they're still having pain. And what could be the possible cause of that pain? So remember that whenever you do any form of surgery in the abdomen, I think Dr. Daley spoke to it earlier, you can get what are called adhesions, which is pretty much like scar tissue, right? And the scar tissue can cause the organs inside the abdomen to stick together or move in certain positions and get fixed in certain positions that aren't natural positions. But that scar tissue that is there can actually cause you to have, persistent or what we call chronic pain, unfortunately. So a lot of times, you may need either pain medication to help with that or, physiotherapy to help with that as well.
Can a
Definitely.
C-section cause rapid weight gain? No, a C-section
No.
cannot cause rapid weight gain.
No.
Right? A lot of people think when you have C-sections, you have this, what's the word, a little overhang for the lower abdomen. Sometimes the main cause of that is because the scar tissue is actually pulling down the muscles of the lower abdomen. And a lot of times you can just fix that. Just free up the scar tissue. You can do that in the office. I've done it a few times.
You call fascial release or something.
Fascial release. Myofascial release. Just release the scar tissue.
Yeah.
All right, guys. I don't want us to get cut off.
Cut off again. Let's say our goodbyes.
This was great. Thanks for the feedback, everybody. It was great. I think everybody enjoyed it.
Big up to everybody that was in the chat for sure. We love the support.
Yeah.
Everybody that participated. Big up.
It was great. It was great. We'll try to do it again. I don't know when this is. The last time I did one was during COVID.
Yeah.
Yeah, but we'll try.
COVID done?
COVID no done, but the peak of COVID.
No, the peak of the pandemic, we're on lockdowns and stuff.
But we really need to try and make it. We need to try and make it more frequently.
A little more often.
More frequently.
What you can do though, guys, you can probably shoot any one of us, any topics that you may be interested in us doing a live on. And
something we haven't done before.
Yeah, something we haven't done before, and we'll go through everything again.
Yeah. Something we haven't done before. Just let us know how we can agree with it and can get this done.
Yeah.
Thanks again for
lunch.
Bye.
Big up everybody.
I'm going to save this and you guys can share it. I'm going to save it.
Yeah, man, for sure.
All right, everybody. Night.